here's some of the key best practices. They've been alluded to already. Build a team of the clinical champion. And this is one of the hardest things to do. As was mentioned earlier, the group's got a million things to look on. The docs have a million things on their plate. What do you want to focus on? Let's see, hypertension control will say 1 in 6 from death in the next 2 years. Yeah, I can probably get behind that. And you get somebody to be clinical champion leader. In a previous life, when I was at a group, we had a young internist who decided to take this on as our clinical champion. And when we, the next one, you see their public reporting of results by provider. This is why medical directors usually last only 3 years at their group. When they start doing that, sooner or later you get enough people angry. Rob, you keep moving. I see that's a So you show those results, and invariably, what's the first thing they say? The data is wrong. And the next thing they say is, that's not my patient. So when I was in my old group, I got permission from our board of directors to show the data publicly. So I showed the data publicly at one of our provider meetings. And of course, one of the lowest score was one of our cardiologists, 33% hypertension control. And he was one of the founding members of the group. Naturally, right? Scott? Yeah, well, that data's wrong. Well, let's see. I was ready for that because that always happens. So I picked up his list of 98 patients. Starts looking at that. This is in front of course, the whole community. Patient number 4 there, that's not my patient. Which one's that? Number 4. Okay, Bill. What about the other 97? So that pretty much took care of that. And then the internist who literally was right next door to his office said he'll be the champion, and he went ahead and did it. And the other things we did there, we used an algorithm, adopted the algorithm, which you've seen many times here. We had a registry to identify his patients, and then we used a pharmacist as part of the care team. Now we've been doing that with Coumadin Clinic, the anticoagulation clinic, for a number of years, right? Now think about it. You're going to have a pharmacist deal with something that is potentially very deadly, very complex, and all that, but do you want to let him work for hypertension control with you? And that was the reticence, so it made no sense to us. So he went ahead and started using the pharmacist, and within 2 months, his hypertension control numbers went from 54% to 78%. The next quarterly staff meeting, we showed the numbers, and we showed what happened with those numbers. And that same cardiologist said, can I get that pharmacist also? Next thing, we had the problems in a pharmacist. So that's another story, how to get enough resources. So here's our numbers. Again, this is through measurement year 2018. Just went through those. A couple things I'd like to point out. Our numbers for hypertension control actually went up from where we started. That's a major miracle for us, even though the percentile stayed about the same, 50 percentile. And the reason I say that is, hypertension control is measured with supplemental data. And to say we had challenges with our supplemental data when we started this was an understatement. We're finally getting a handle on this. So I anticipate for 2019, this number is going to go up quite a bit. But part of the issue is you've got to have good data, right? You've got to have good data, you got to have people who care about it. So we're getting that fixed. Eye exams, we went up 7 points, and we actually stayed at the same percentile, 25th percentile. That's a good thing because that tells you the rising tide is lifting all boats. Everyone's getting better at that. We're funding programs where we're helping to fund the digital retinal exam cameras. So we're working with provider partners to make that even better. A1C testing, we went down from 90.33, we went down a little bit, and we dropped right off the cliff with the percentile because that's a very narrow band. Same with the diabetic nephropathy, we went up a little bit, but we stayed at the 25th percentile. Look, last year, 91%. So literally, it's a 1% difference. It takes you from the 75th to the 25th percentile. So yeah, we got some room to do, but 90% isn't too bad. And poor A1C control, that one is going all over the place. Very widely varied one. When you talk to our friends at Kaiser, who do they focus on? They don't focus on that group of folks. We encourage our providers to work on that 7 to 8 and that 8 to 9 group. The 7 to 8 would be the ones that pop up, and you want to make sure you keep them in good control. The 8 and 9s just need a little work, and you can get it back out under 8. So that's more good stuff we learned from our buddies at Kaiser. The other thing about the database that you have to have, I heard electronic health records. So if you're in an IPA, how many different health records do you have? 4 or 5 sometimes. How many do you have? 40 different health records. another stat you probably didn't know. What percentage of California physicians have no EHR? 30%. So we're actually working with California Quality Collaborative on trying ways to mitigate that. 30%. California, home of Google and Apple, 30% still don't have an EHR. Why do they not have an EHR? Now I'm speaking from a provider's perspective here. I give you 2 reasons. Does it help me with efficiency? Does it give me more money? Why would I do it? Okay, because EHRs were not developed for doctors seeing patients. They were designed for billing and a whole bunch of other stuff and meaningful use. I don't know if it's meaningful or useful, but that's what they were designed for, not for helping providers in their efficiency and their interactions with the patient. So another thing about that. So what are we going to do in the future? So we've done some improvements. We've got some momentum going forward. We're going to continue to participate in the university best practices, and we're in various leadership roles throughout those. Continue to expand provider partner participation. This is probably the thing that's been a long overdue. So we have some really great partners, provider partners that we work with. And a lot of you are in this room. But are these the people we need to reach? The people in the room are doing this stuff already, right? You guys are the motivated ones trying to make things happen. How do we reach those other provider partners that aren't really engaged and haven't really worked on this yet and really don't seem to be focused on anything because they say there's just too much to focus on? I would submit this is an important thing to focus on. We're going to continue our work with supplemental data submissions. Again, that's going well. We're working with the San Diego Accountable Community for Health work on social determinants of health, or whatever you want to call it. So that's a nice pilot that's getting started down there. And we're going to participate in raising awareness through national regional partnerships, including work with Betsy's office on the CDC National Hypertension Control Roundtable Organizing Committee. Say that 3 times fast. Okay, we can't achieve 80% hypertension control. I hear a lot of talk about getting patient engagement. Parag, when you were at Sharpie Steele, how much patient engagement did you guys spend money on? 0, right? Who did you spend the money on? Getting the providers engaged. We can do this by getting our provider partners engaged. Getting the patients engaged is a laudable thing too, and that'll be necessary to get us past 80%, but I submit you can get 80% working with your provider partners. We can eliminate the strokes and heart attacks by attacking the 3 modifiable risk factors of diabetes, hypertension, lipid control, and provide that care that's worthy of our family and friends and sustainably affordable for all Californians. Thank you.
Thank you, Scott. And I know you're going to get some questions, maybe some challenges when we get to the response section. But I appreciate you sharing what you did. And we absolutely look forward to the 2019 numbers, which I promise will be much better.
Our hypertension has only one way to go.
So with that, I'll turn over to Jean Shadad-Curry. Did I get it close? Okay, with the VP for Medical Affairs at HealthNet Centene.
Hello everyone, hope you're enjoying this day with a lot of wonderful information. Each time I come here, I keep thinking Hattie needs to do this overnight camping with 2-day thing so we can go out, chat with each other, get our questions answered, and then come back. But it's a really packed day, and thank you for inviting me over again this year. I feel like I have earned the club membership now. So looking forward to present our annual progress update for HealthNet and California Health and Wellness, which is the Centene Health Plan up here in Northern California. Which way do I point this?
To the right.
Oh, okay. So this is something about what our landscape is like. We heard somebody say the top 4 health plans capture about 70–80%. Centene, yes, actually insures 1 in 15 in the entire nation. And we here in California insure about 1 in 10. So we have about 2 million Medi-Cal members, 10,000 dual eligible, which is Medi-Cal Medicare, about 172,000 Medicare, and about 642,000 commercial. We have a mix of the membership being in the delegated models with the provider groups, and also fee-for-service, which is the providers running their offices. So we get our data both through claims and encounters, which is a challenge. Like Scott said, it's a lot of it is data. And we don't think what we reflect here in our report cards is an actual reflection of what's going on in the market. However, it's a continuous effort to capture more and more data of how people are doing things, including the Mexico medications. So this is our integrated approach. Member in the center, we focus around life, health, wellness, pharmacy benefits, behavioral health. Social determinants of health is in here, vision, telehealth. As you can see, member in the center, a lot of care coordination is needed in the benefit management, a lot of IT infrastructure is needed, and a whole bunch of person-centric programs to engage the actual member into preparing for themselves. I don't have to show this. I think a lot of you have seen the correlation between diabetes, heart disease, and hypertension. But when we did our analysis for our health plan, we had about 183,000 members with diabetes with some kind of history of heart disease and hypertension. And we realized out of our entire population, only 40%, 60% of the population was on the aspirin, ACE, ARB, and statin, and 40% was on nothing. So we knew we had to do something about it, and kind of got a real sense of urgency amongst the leadership and started this program. So our goal here was simple. We took all our diabetics more than 55 years of age, which was kind of mimicking Jim Duggan's study, but also to kind of limit the denominator, so with our limited resources and capturing the highest risk. So somebody who's over 55 with diabetes, with heart disease, with hypertension, we wanted to ensure that this membership was on aspirin, over the counter, less than $2, a statin, and ACE inhibitor. So a kidney drug, a cholesterol drug, and aspirin. And we didn't care which brand, what dosage, we just wanted one medication from each category to have that cardioprotective effect on the members. To ensure compliance and adherence, we recruited our healthcare coaches who were dietitians, nutritionists, diabetic educators, to engage with these members who obviously had more time to engage with the members and assess the level of motivational interviewing, kept the members engaged, kept them educated about their condition, and kind of troubleshooted all the barriers that they have navigating through the healthcare. So if anyone of you has a family member, you know the number of times they reach out to you on understanding how to navigate through the benefit system and the healthcare system. So these coaches were doing just that. So our short-term goals were to get the provider and the provider groups to start prescribing these medications to the members who were not on any medication. Now, in the course of our data and our reports, when we were distributing these member lists to the providers and provider groups, we noticed that a lot of these members weren't filling their prescription. So the doctor had prescribed it, but the member, for whatever reason, copay, transportation, didn't understand why this other blue pill has to be there or red pill has to be there, just didn't refill or didn't continue their medication. So the short-term goal was to partner with the providers and provider groups and give them the actual member lists of how many of their members were on this bundle and how many were not. And all these members have all the high-risk factors. The long-term goals, of course, was to get the members themselves educated about their condition, bought into the treatment, or even ask their doctors about the medication. Also with the activity and diet regimens that the coaches were advocating. So these were the supporting activities, and I'm glad to say if you compared this slide from our last year to this year, there are many more honeycomb boxes added to this. So we're adding more and more support activities, and if you notice, it's a variety of clinical mentors who are talking to the provider groups, to online tools that the members can engage at the pace they want, at the time they want. It's called My Strength. All the members, all lines of business have access to this. My Strength has now added a lot more modules on anxiety, depression, pain, because as we're seeing more and more of this, there's a cycle of behavioral health conditions either leading to the chronic conditions getting worse or the other way. So we knew very soon we had to get to the behavioral health component of it as well. We have case management who deals with our highest risk members. We have clinical pharmacists as shown. There's no doubt about pharmacists adding value. The only improvement from last year to this year is we actually have a stand-up pharmacist team, which has now gone to 18. Now, they're not all doing right care initiative work, but a good chunk of 4 or 5 pharmacists are doing right care initiative work. And as we show more and more ROI on the utilization, we're able to get more and more FTEs. Steve knows because I've hired, or at least referred him to hire some more students for us. So disease management vendors, they are Omada, Optum, EPC, there are a whole bunch of vendors that offer disease management services, and then there's involved pharmacy solutions that has IVR calls or pharmacist calls reaching out to this membership on adherence. So these are our results today. We have utilization rates that have significantly decreased only in our cardiovascular events. So we didn't show an ROI that had utilization rates across the board, but just specific to cardiovascular events, where patient engagement increased and net promoter score increased because of that. We had 43% of the members with that had diabetes that were not receiving any medications were now receiving some kind of medication. And we had utilization cost savings by line of business that shows there by 60%, 27%, 17%. This is our reporting year 2019 performance. So I kind of took heavy supplies and made it kind of easier to read. So we have check marks here. The single check mark shows that we reached our 75th percentile with the measures listed on the left. And there are some abbreviations, but they're around blood pressure, diabetes, and hemoglobin A1C. And then the double check mark are above the 90th percentile. So few of them, but at least it's a start. Now what Scott didn't mention is each year the cutoff points increase. So we're like chasing a higher target, so it is a higher height, but the targets do increase every year. This is opportunities for improvement. This is by line of business. The blues are where we still need to reach the 75th percentile, and the dark blue, a few of those are just where we missed 1% or less. It's funny, when I was preparing the slide deck, somebody got really defensive on the phone and said, we just missed it by 0.4, which was nice to see. They're so passionate. So I said, I'm going to change it. So you can see how close we are to the 75%. These are the HEDIS measures. Now, this can be used multiple different ways. For organizations, peers, regulators, they really care about the 6 HEDIS measures and how we perform. For the providers, a lot of people get incentivized, and their contractual incentives are built in for if they perform on these 6. So it's just a lever and an incentive to let them know that it does help capture 6 of those HEDIS measures, kind of in just one visit or one call when the member is there. So usually they overlap. But, so all our coaches, when they're calling the member, they're addressing all the 6 and more, and wellness and diet. But these are the 6 they make sure they close care gap on. Some of the initiatives, like Scott and I were describing, we do partner really, really closely with our providers, not just provider groups, but also the providers in the community, the FQs. We do a lot of in-home visits. We have a lot of incentive programs. We have now the live calls with our pharmacists. These pharmacists get only more empowered if you have things like collaborative practice agreements, which we're now starting to have with the provider groups. That's a really big ammo to give the pharmacist to do the things that providers not necessarily getting time to or is not comfortable doing. But then the information does go back to the PCP, and that's the part you have to ensure that's happening. We have our commercial and exchange, some of the activities. So we have a self-testing hemoglobin A1C where they have a drop of blood and mail it back. If somebody can't make it to a provider's office, this is an easy way to get things done. We have for Medi-Cal and CHW, we have the one-stop clinic program that we started. That just gives flexibility for the provider office to open after hours or weekends, and the health plan, which is us, we fund for their staffing to come in or provide our own staff to do it. But this is very well coordinated, where we get the target set of membership, we see the density of these members in that area, and then we convince the providers to open their doors after hours or weekends. And this has worked out very well. Of course, we have vendors who take out portable retinal cameras, so that helps in case the equipment is an issue. We have incentives. Well, unfortunately, the members and the providers are driven by incentives, and they do work on steroids. Once you have something like $50 or if they come on board. I mean, it's unfortunate, but it works. It works. And these are the highest risk members, so we do want to reward them to come. And sometimes they use those $50 to get a caregiver to take care of their kids and make it to the provider's office. So it's not all that. I mean, I think sometimes this money goes to really enabling them to make it to the provider's office. For Medicare, we have some toolkits, tip sheets. We have a large employer. I mean, there's a very different relationship with the employer group and their members. And the employer has a really vested interest to keep them well. So we've started this doing with some UCs and some other employer groups where we're giving them ADA diabetic subscription, and then the Let's Be Well toolkit that has some little goodies, and then the AHA blood pressure guide with stress reliever. And then we had an award here. So I think we've been getting this award every year since I've been here. So we got this participant award last week on being the participant with the Target BP program. We also got another award that I have to mention that didn't make it to the slide deck 2 weeks ago on eValue8 National Alliance Forum in Washington, D.C., where all the purchases and the large employer groups attended, big audience. And the good thing is they're all interested in wellness programs, preventive programs, more than they are on the acute episodic care. So that was great. So we actually won an award there amongst Geisinger and Kaiser. Kaiser didn't win it, we won it. It was a tough competition. Take Charge of Your Health is an online program, again, self-paced, educational for Medicare and commercial members. We have Omada, that's a digital way where the online peer group is a support group for the patients. They offer a 16-week online program around weight and diet and wellness. And now they're getting to pre-diabetics also. And we have a wellness webinar series for the providers and I'm sorry, for the members. So 1,754 members attended this. It's pretty well attended. This is the newest thing, which is more in-home, focusing on where the patient is, when the patient is, and a very ongoing monitoring. So this is a Bluetooth-enabled glucometer that we have partnered with that gets sent out to the testing diabetics at highest risk. And then an educational coach gets on board, and then they get real-time readings from the member from home. So if there are any mistesting or outlier values, they see the coach gets on the phone with the member and says what's going on, Thanksgiving, or you had a lot of cake, let's get back on it, and things like that. But this is really good because it's in a setting they like. This is the other thing, social disparities of health couldn't help but get into that. We have this project, a pilot actually that we're doing on med adherence, but focused on the Chinese community in the LA area, San Gabriel County, where we're trying to figure out barriers to adherence for this community. And you'll be amazed at things that are coming through, which is like alternate therapies, herbal medicines. They have a heap in the cabinet saying, we have everything under control, but we're not taking statins, we're taking all these other. And the PCP seems to be in support for that. So, we have to account for that kind of behavior with the members, which not necessarily is that. And so that's it. Any questions?
But we're not going to take questions just yet because some of you may be a little confused by the agenda, as was I, as the moderator. But our next the next session is actually part of this one. And so we have a few people that are lined up to talk, to get some responses and maybe some change ideas for the starting with Rob here.
So the health plans are under merger agreement orders to report into the University of Best Practices. So the second part of this agenda item that Parag is part of is the response from the University of Best Practices. Parag is one of our award winners, and he's a longtime leader of the Right Care Initiative, both in Sacramento University Best Practices and San Diego University Best Practices. So sorry about the confusion.
And soon to be Hawaiian.
Parag, before you get started, maybe just to kind of smooth things up as we go through, we're going to also hear from Steve Chen, who you all know from the University Best Practices in LA and the USC School of Pharmacy, Christine Thorne from San Diego University of Best Practices and UCSD, and I think Nirali might chime back in as well. Matthew Wanacott was not able to be with us today.
So thank you for that introduction and good afternoon, everyone. So I think RightCare has been a great learning collaborative. It's like a family, and it has really helped us to have some best practices which we have taken back to our provider organizations. And really, because it has been a trendsetter, we have been able to move the needle in the last decade. So my comments are based on, where do we really go from here, and is it really time to measure outcomes that really matter? So the objectives, it's a brief presentation, is to see really, should we start measuring outcomes that matter around cardiovascular disease progression, and also around the value-based care, that is it time to pay for outcomes that matter most, than rather than simply process-based measures. Like, for example, when I say process-based, like for example, measuring nephropathy for a patient with diabetes or something like that. So I think we all know, and Dr. Shortell and Hector have done great work around this, but overall, we all are moving into a value-based care model. There was a recent survey and the Indian Catalyst, 42% of healthcare providers think that value-based care will be their primary source of reimbursement. Which means that, it's not that other people don't think about this. What they're saying is other people might say it might not be the primary, but it might be the secondary. But still, in the last 12 years, we have moved from majority being fee-for-service type of model to at least talking about value-based care and trying to bring it down to our providers. But process-based measures and this control-based measures are important. Just to give an example here, RightCare initiative helped us. When I started at UCSD, our blood pressure control rate was low. It was low, around 73%. And over time, adopting all the best practices which we have, I have learned through this collaborative, we were able to implement those, and you can see we are starting to make improvement on our blood pressure control rate is at 77%. Which is all great, but when you start looking at from a payment perspective, and when you see if you participate in P4P program, which is now called AMP program, or the merit-based incentive payment system, which some of you must be participating, the overall the dollar amount which flowed down to per measure per patient is very, very small. Under the MIPS program, it was around 2.7%. And if you look at all the measures which are there and all the EHR and all the things which we have to do, individual measure per patient dollar amount which flow down is pennies of dollars. I'm not saying I appreciate that over 12 years. I thank the health plans, I thank everyone that whatever check you have given us. But does it really help us drive the fundamental change which we need to drive the team-based care model and all those things? We can learn of all the best practices, but when we go to our C-suite, to in front of our finance people, do we really get their attention, right? When you're looking at a billion-dollar industry, when you're trying to go and say, hey, can I get $300,000 for this? It's very, very difficult because you're going to say, I'm going to move the change by $20,000, right? So, first of all, thank you for paying attention to this slide for all But I need your help as RightCare leaders and collaborators. How do we get into a different stage in the next decade? And I start with this, are process-based measures enough for us? When you look at Tale of Two Cities, I picked Sacramento and San Diego. Those are my favorite cities because I live in San Diego, I was in Sacramento. I still like the red bunny rabbit every time I come down the stairs at the airport. So please don't ban me for saying this. But I think when you look at diabetes screening rate, two cities both have almost, this is based on IHA commercial 2017 data. You can see Sacramento and San Diego both have almost close, diabetes screening rate. But when you look at the cardiovascular surgery, the CABG, Sacramento has much more higher rate of CABG than San Diego. And when you look at total cost of care, Sacramento is much higher than San Diego. This is not causation. I'm not saying that this is exactly related. There are many, many layers to the total cost of care. But this is an association I'm trying to draw based on some data point. So, but I think things which really matter, when you look at the paper which has been mentioned many times, and I, along with Christine, we were involved in the Be There CMMI grant, where we, had to really put the boots on the ground, trying to get the 9 systems to participate in this.